So we'll move on to the next case. We invite Dr. Resmi Bhaskar.
She's a pediatric ophthalmologist. She's a consultant in Chaitanya Eye Hospital, Trivandrum. She'll be talking on a case, Crossed Paths, Unraveling a Case of Strabismus. Over to you, Dr. Rashmi.
Good morning. Thank you, Dr. Soumya and KSOS for giving me this opportunity. My topic is Cross Paths, Unraveling a Case of Strabismus. So my case is of a 4-year-old female child who was referred to me from Maldives for squint surgery, deviation of right eye noted since 9 months. As per their parents' history, the child woke up from sleep and suddenly they noticed that the right eye was squinting. There was no history of any fever, any illness, trauma prior to onset of squinting, no history of any long hours of screen time, no complaint of double vision, no other complaints was there for her. They consulted the local hospital. There, the MRI was advised from them, which was normal. They advised patching, but the child was poor complaints with patching. After 9 months, again it was the same picture. So they sent to us for surgery. This was a photograph of her just 1 month prior to coming here. That is after the onset of squinting. And her 1 year back photo was like this. And at 1 year, she was like this. So in clinical examination, vision in the right eye was 1/60, near vision less than N36, left eye 612 parts, improving to 66 parts. She had a right convergent squint with a right hypertropia. There was around 45 prism isotropia as per Krimsky and 10 prism hyper. Extraocular movements were full except for a 2 plus inferior oblique overaction in the right eye and 1 plus in the left eye. Fundus was like this, showing a mild torsion in both eye, right more than left. So we did a investigation, we dilated, and the retina specialist opinion was taken because no other thing was there to account for the defective vision and sudden onset of squinting. They advised a flash VUP and an FFERG. We sent to the pediatric neurologist. They were not very much happy with the MRI taken from Maldives, so they repeated the MRI, which was normal, and they did the myasthenia workup also, and no other neurological to account for that. We did a flash VEP which showed a amplitude reduction in the right eye as compared to the left eye, which could be explained with the poor vision in that eye. FFERG, right eye showed a scotopic better than photopic, but photopic waves were poor, and left eye it was okay. So we were confused. What was the reason for the acute esotropia in this child? And because there were no other factors to account for it, but sometimes we see when we see a lot of acute comitant esotropias these days, but there may not be any reasons for that. But in 9 months time, seeing this much dense amblyopia was not very common. We see a lot of acute esotropias, but they develop almost around 612 maybe the probable vision, but 1/60 within a period of 9 months were not very common that we see. And FFERG also, in usually the FFERG will be normal in case of amblyopia. Multifocal ERG and pattern ERG can be reduced, but usually FFERG will be normal. So regarding keeping in mind all these factors, I was a little reluctant to plan surgery. I wanted to do patching, then plan for surgery, or do surgery, then advise patching, because the child was from Maldives, will not be getting for regular follow-up also. But still, I went on for surgery and I did a right eye MR resection plus inferior oblique resection and LR resection. And the third postoperative day, the child was okay, vision remaining the same. I gave her the glasses. They wanted to go back within a week. So I gave the glasses, best corrected vision, and advised patching the left eye for 6 hours per day. 3 months back, she came back. Her vision improved to 624 parts N80, and left eye was okay, except for a small hyper in the left eye. And she was good complaints with patching this time. And we are waiting for her follow-up. She will be coming next month for the second follow-up, that is after 3 months. This she came in September. So my question is whether you have encountered such a dense amblyopia within a short span of 9 months.
Possibility is that maybe the child would have had
Pre-existing.
amblyopia, and maybe it was small angle esotropia which would have decompensated in a period of time. That could be one possibility. Otherwise, it's difficult to explain. But maybe you have to follow up with the fundus examination. I think sometimes things might unravel as the child grows.
Yeah, only one follow-up we have got. She'll be coming only in December.
Any neuroimaging was done for this child?
Yeah,
It was
neuroimaging was
normal.
done twice. From Maldives, it was done, which was normal.
With
After coming to Kerala, also they did one more time because the neurologist was not happy with the previous neuroimaging. So they repeated the neuroimaging, and MRI was normal the second time
with
also.
contrast.
With contrast. Yes. They did a full neurology workup.
What was the refraction for her?
Refraction was plus 0.5 with minus 1.5 cylinder. We did a atropine
Only a
refraction.
cylinder.
Yeah,
okay.
only cylinder. No,
Was an OCT done for her?
no, OCT was not done.
Yeah, OCT would have been helpful at least to know if there was any pathology, because the full field ERG, which is the dark adapted, cannot see very well in this. The light adapted responses were flatter.
Yeah.
Yeah, the dark adapted, even you can see
Little bit was
dark adapted also were not good, isn't it?
Yes.
You can see the dark adapted, the top, the A wave is not there. The maximum rod-con response is okay, but
But comparable to the left eye,
Yeah.
the left eye appeared to be okay.
okay, this is right, that is left. Huh? This is light adapted, this is dark adapted, right? But the top wave that's flat, isn't it?
Yeah.
The top is flat.
The right eye.
The right eye, left eye also hardly anything. But maximum rod-con response is there.
She's only 4 years. And
Yeah.
It was under
So was it
pedichloric
under
sedation.
GA or
Sedation, under pedichloric
Yeah,
sedation.
sometimes poor cooperation can also produce this. But if you're suspecting some photoreceptor dystrophy, it's a good idea to repeat it.
Yeah, when she comes for the next visit, we thought we will plan for
Yeah,
big
because
ERG.
yeah, so common conditions which we mistake is retinoschisis, but here the B wave is good in the maximum rod-con response. There is no negative B wave. So all those things we may miss it because we are not doing 90D and all that. Sometimes we may miss all this, but it will be usually hypermetropic.
But we did an atropine
Yeah,
refraction
so
also, but
nothing.
hypertropine.
So another thing could be like, yes, she said it could be a decompensated
Decompensated, yeah.
small angle ESO, which became a tropia. But definitely there was inferior oblique overaction with
Definitely
V
inferior.
pattern.
Maybe she might be having a eccentric
Pre-existing.
fixation along with an eccentric fixation is possible.
But within
I
3
don't
months,
know.
she improved to 624 parts.
624,
Actually, one follow-up we had, but she improved to 624 parts. That was actually
I think
surprising
maybe-
for me because
yeah.
I didn't expect that much improvement in just 3 months.
I have had cases where, as she told, there is a microtropia and long hours of mobile after that, that goes in for a acute committant esotropia. So such cases I have had.
Yeah, but this much severe amblyopia usually we don't see in,
don't see,
in
yeah.
acute
Yeah.
within this
Another
short-
thing is that the mobile usage need not be long hours also. I have had cases where the child was using or the youngster was using mobile phone, especially in the supine position. There has been a recent published study where they say that the mobile usage in supine position and in most the history is there. So 1 hour or something like that they would have used at night, and the next morning suddenly there is a large
This
angle
child, they
squint.
didn't have any history of long hours of
didn't-
mobile
yeah, yeah,
use
you
also
have.
because she was from Maldives. So they told her she'd go out and play only most of the time.
Okay.
Thank you.
That was also ruled out by the neurologist. We have asked them to rule out myasthenia also when we sent to neurologist.
Thank you, Dr.
Thank